Chapter 14, Principles of the Assessment Process. So let's start talking about how we gain more knowledge about our patients, about their conditions, and their history so we understand what's going on with them. First, we have to have the history of the present illness, what's going on today, and then any relevant past medical history. And we need to kind of be able to sort out what's relevant according to what the current illness is and what's not relevant or what may be a contributing factor. So some important decisions we have to make. When we're talking to the patient, we're trying to gather the information we need, and we're trying to get them to be comfortable enough to tell us a truthful response of what really is happening to them. The patient is our primary source, but sometimes we gather additional information from family members. They may know or they may have some ideas, and you can always compare what they tell you with what the patient tells you. Bystanders on what may have happened and what they've seen happening in the past. We can also look at the medications the patient has sitting around their residence or on their person, or maybe a list of the medications. And then just our general observations of the scene. If you walk in and the first thing you see is the oxygen generator and O2 tubing going to your patient, there's a hint that they may have a respiratory problem. So we're looking at what may be going on around them to give us some ideas of how to focus our assessment taking. So the first thing we have to do is in the first 10-15 seconds, establish a good relationship with our patient. Introduce yourself, ask them their name, ask them what name they prefer to be called, and talk to them in a pleasant manner. Ask sometimes open-ended questions, sometimes you need to get more specific. If you ask an 80-year-old man, have you ever had any medical problems? You may want to try to focus that in on the last 10 years, 15 years, or anything related to what the chief complaint is today. Or they may have never had any medical problems at all, so you're going to have to adjust your style based on what your patient's telling you. If you need an immediate answer, use closed-ended. Are you having chest pain? Does it go anywhere? Does it hurt really bad when you press on the chest, or is it just constant? So those are some closed-ended questions that give you some more very specific information to work with. And with all this information you're gathering, you're trying to paint a history of the patient so you can figure out what could be wrong and what is wrong with them right now. We use a mnemonic, OPQRST, that helps us understand how to assess pain or any type of discomfort. So we're looking for onset, provocation, quality, region of radiation, severity, or time. So this is something you need to memorize. But onset, we need to know what were they doing when this started. Provocation, does anything make it worse or better? Does it change? Quality, how do they describe it? What kind of pain is it? What kind of discomfort is it? Region or radiation, where is it, and does it go anywhere else? Severity, use a scale of 1 to 10, 10 being the worst pain they've ever felt, and have them rank it. It's a very subjective ranking, but as you progress with treating your patient and providing additional support, they may change that number on you and help you gauge whether what you're doing is giving them some relief. And then time, how long has it been going on? And this is the one where you may get a 5 years, 10 years. Well, how long has this particular episode been going on that's caused you even more pain than normal? So kind of weave these into your discussion with your patient. You don't have to ask them in order. This is a mnemonic for you as the EMT to remember what's going on with your patient. It's not for you to ask the patient, what's your onset? What's your provocation? If you ask them that way, you're not going to get the answer. The other thing you want to do is if you ask a question and they maybe give you an additional information, yeah, it started about 30 minutes ago when I was mowing the lawn. You don't have to ask time now. You've already got the time answer. Because when you ask it a second time, they know you're not paying attention. So listen to what your patient says and use this as your reference guide on what information you need to gather, not in order on how you have to ask the question. Signs and symptoms you're going to get by just asking them the simple questions and maybe doing a hands-on assessment. Allergies, we're going to take that out to what kind of medication allergies do they have? What kind of environmental allergies do they have? Have they had any reactions or exposures to what they're allergic to? Medications, we're looking for prescribed medications, over-the-counter medication, recreational drugs. What kind of drugs are in their system? Past pertinent history, what's related to what's going on? Could be their history, could be their family history. Last oral intake. This one, be careful. Any of these, be careful how you ask them. Don't just read it off my list here. Ask them, when's the last time they had something to eat? If you ask them when was the last time they had oral intake, that might give you some answers you don't want. So last time, when did you have something to eat? What did you eat? When's the last time you had something to drink? How much did you have to drink? We also take that L and expand it out to last menstrual cycle. So if our patient has any type of OB or gynecological issues, we may ask last menstrual cycle. Or we take it one step further for last known normal when we're talking about people with altered mental status. So the last can be last oral intake, last known normal, last menstrual cycle. And events leading up to the injury or illness, that's what you're getting from your scene size up and your mechanism of injury, history of prevalence and illness. So again, you may have already got these answers. Just use this as your checklist in your head to make sure you've got them. You don't have to ask them in this order. And again, if the patient says, I take out this for this, you know now they've got a history of that. When you're taking history on little kids, use language they understand, and some adults. Take it down to their level, or take it up to their level if you're talking to somebody that is experienced with medical terms. If you're dealing with a mom that has a special needs kid that's taking care of them all the time, 24 hours a day, they probably know more about their disease process than you do. So start asking the questions and gauge this and adjust as needed. School-age kids start to understand what's going on. They may be able to tell you answers. Ask them. Don't go directly for the parents or the bystanders. Ask them to start off with and see what you get. With kids, you also want to interview the parents, teacher, caregivers, anybody else that can tell you what normal is for the kid and what might be a history for them. So let's talk about the physical exam. You can do this while you're asking questions. You don't have to ask questions and then stop and then have a hard break and then go on to the physical exam. So you can be doing both, or because we work in teams, one person can be doing a hands-on assessment while the other person's asking questions. 3 primary techniques we're using for this physical exam. Observation. Look at your patient. Look at the general view. Look at the specific view to the part that you're assessing. So if you're assessing the chest, you may have to move the shirt around so you can look at the chest. You're assessing the belly, you're going to look at the belly. You're going to auscultate. Listen for sounds. So listen to their breathing sounds. Listen to their chest with your stethoscope. Listen without your stethoscope. Listen to their belly. Listen to what happens when you move body parts. Do you hear anything? And then palpate. This is a hands-on assessment. Know where to touch, when to touch, and how to touch, and what you're trying to feel. And we're going to practice all these, but you have to get into the process. So you're getting down on the patient's level, eye to eye. You don't want to be hovering over them unless you're trying to show dominance to get where you are, but it helps to start on their level, and then if you need to, get into the dominating role so you can kind of direct what's going on with them. But eye to eye, talk to them, listen to their name. I always write their name on my glove, so I've got it right there, so I don't have to, I don't forget it. When you're dealing with kids, know they're going to be scared. This is where the teddy bear in the ambulance works out great, or a blanket, or having a caregiver hold them, some way to start getting their cooperation. If they have any pain, start at that body part last. So start away from the painful areas. So they say they fell down and hurt their left arm. I'm going to check their right arm first. I'm looking for least invasive ways to check them. They start at their toes and work their way up. I do not want to scare a kid and get them afraid of me so that I can't assess them. Or I don't want them crying if they're conscious so that I can, so they'll That way they'll answer my questions. Tell the kids what you're going to do. Show them. Try the device on somebody else. Say, hey, I'm going to put this thing on mom's finger, and then now I'm going to put it on yours. See how it changes the numbers. Don't lie to the kids. If you tell them it's not going to hurt when you start the IV and then you poke them with a needle, they're not going to be your friend anymore. So be aware of that and use a little patience when you're dealing with kiddos. So look at the body systems as we go through. Respiratory system, we've already assessed this pretty good with our ABCs, but we're going to take a real good deep look at this one. We're going to look at how well the chest wall is working. Do we have any changes in the lung sounds? Do we have any shifting of the lung sounds? Is what they're doing adequate for life? So on the history of the respiratory, what kind of conditions have they had in the past? Do they have emphysema? Have they had asthma in the past? Have they had any type of lung damage? Do they take any medications? Are they taking it the way they're supposed to be taking it? And then ask if they've had this problem before. If they had, what did they do to treat it the last time? It's always kind of scary when they say, well, the last time they had to put the tube in my throat to keep me breathing. That's when you get a little nervous and you drive a little bit faster, get them to the hospital, a higher priority, because they've already told you it went bad last time. So let's prevent it from happening this time. So on the physical exam of the respiratory system, mental status, remember the first sign of respiratory difficulty is altered mental status. So that's going to be one of our pieces we put together here. Looking at their effort of breathing, look at the chest wall. This is where you remove the shirt or you move the shirt to the side so you can see the chest wall. They'll go in and out. You listen to the lungs, get a pulse ox, look for edema throughout the body. Edema in the lower extremities and the low back says there's something wrong with the lungs. And we're going to talk about congestive heart failure more in the cardiac chapter, but this is something you're looking for. We're also looking for fever. Fever is the way the body reacts to infections. If they've got a fever, then that means they might have some type of lung infection. So move over to the cardiovascular system. Heart, the blood pressure. Are they in shock? Are they having vascular problems? These are all questions we're going to look at to see if there's a problem. Do they have existing conditions with the heart? Or do they take medications to say they have heart disease? Are they taking blood pressure medications? Are they taking cholesterol medications? If the patient says they're taking a certain medication, you're not sure what it is, ask them. They probably know. If not, look in one of your little cheat sheets that we all carry in our pockets, the little EMT guides. Look for signs and symptoms of what's happening right now. You can use your OPQRST to kind of narrow in on the causes, but again, use that in your mind, not as a tool to ask questions. And then ask how the discomfort goes. Look how bad it is by perfusion to the distal extremities. Get the pulses wherever you can, and if they're absent, note that. Get a blood pressure, notice what it is. The pulse pressure is the difference between the systolic and diastolic. The closer the pulse pressure is together, so like 90/86, that says there's not a lot of space for the heart to contract and expand between beats. So that's something that tells us there's a problem inside. Jugular vein distensions. Jugular veins go up the side of the neck. If they are bulging out, then that shows you we might have a problem. That says there's a backup somewhere in the system, probably in the lungs, because the heart's not able to push the blood through. Palpate the chest. Does it hurt when you squeeze? Does it hurt when you push on the sternum? That may be telling you there is a trauma versus a medical issue. Look at your patient. You've already done this with your scene size up, but look again. Make sure you understand where they are and what they're doing with their body. We're checked the mental status initially in our ABCs of the APU, but again, go back and look at it. Maybe look at dysfunctions within the body. Are their grips the same? Can they squeeze your fingers on both sides the same? Can they move their feet the same directions? Can they feel all their extremities? Can they follow commands? Do they make sense when they talk to you? So these are all clues there's a problem with the nervous system. Get the basic mental status, that's the AVPU. What's the normal functioning status? Ask people that know them, what's normal for this person? Maybe they're always confused. Maybe they don't know where they are most of the time. That's another thing. If they don't know where they are most of the time, and today they do, that's a sign too of something you need to document. Get a history of their neurological problems. How long have they been having issues, and how have they progressed? If it's fairly recent and it's a sign of a stroke, if we can catch it within the first hour or so, they have some ways to fix the stroke completely. So those are key things for us to look for and document and identify as something we need to change. Note the speech patterns. What are they saying? How are they saying it? Are they dropping words? Are they unable to think of the right word? Are they slurring their words? All clues there's a problem with the neurological system. Do the stroke scale. We're going to talk about that in our neurological chapter, but just to do a quick assessment of the stroke, the body, to see if they're having a stroke. Peripheral circulation, we call that circulation motor sensation. So CMS, I check the pulse in the wrist and the ankles. I check the motor function. Can you move your fingers? Can you move your toes? And then sensation. Which toe am I pushing on? Which finger am I grabbing? Gently palpate the spine. Look for the pupils. Are they equal? Are they round, reactive? If they are ambulatory, watch how they walk. That gives us a clue. If they're dragging a foot, or something is not going right when they're walking, or they're walking in circles, ask if this is normal and try to figure out what's wrong. They're all clues we're using to put together to form a picture of what's going on with our patient. The endocrine system, the most common thing we're going to run into is diabetes. The diabetic patient that's hypoglycemic or hyperglycemic are going to be the ones we run into. So diabetes mellitus or sweet urine, don't ask me how they found that one out. Current medications, what are they taking? Is it being taken appropriately? Do they take insulin? Did they take what they're supposed to? Did they have any changes after they took their insulin? Did they overeat? Did they undereat? Did they use more energy than usual? And then they took their insulin, they had their lunch like they planned, but then just out of the blue, the cops decided to chase them and they ran 2 miles and used a lot more energy, and now they're having a diabetic reaction with low blood sugar. Happens a lot. Maybe they're sick. Maybe they took their normal medication and they vomited all their food out. If they are diabetic, they probably have a glucose monitor. See if they've taken their blood glucose levels. If they have a glucose or an insulin pump, that is not something we can adjust or use at all as EMS providers. So just ask if it's there and if it's working normal. And the patient should know. If they don't know, it's something to note. Check their mental status. Look at their skin. If they're having diabetic emergencies, their skin's going to do different things based on what's going on with their glucose levels. Take the glucose reading through your glucometer. Look for the insulin pump. Look for their jewelry. If they have a necklace or a bracelet on, or any notes on their body that say they have a insulin dependency or diabetes, that's a good clue for you. GI issues. What's gone in, what's come out, and what's it look like when it comes out. It's pretty simple. If it's active bleeding, it's red. If it's older bleeding, it's coffee grounds or black tarry looking. So that's a simple one to go through. Look for pain or discomfort in the belly. Where is it in the belly? What did they have to eat last, drink last? Do they have any issues of problems with their GI tract? Bowel movements or gut vomiting. What does it look like when it comes out? How much has come out? What was the color or the smell of it? All interesting things to document and try to form a history with. Look at their body position. If a person is really having abdominal pains, they're going to be in a fetal position. They want to take all of the pressure off the abdominal wall by getting all curled up in a ball so the belly doesn't, the abdominal muscles don't press on the belly. If you have abdominal pains, we're going to have to assess them. When you're doing that, you want to push on the quadrant that is painful last, because if you push on the quadrant that hurts the first, they'll never let you push them again. So that's the last one you press. So they say it's the lower right quadrant that hurts. I start upper left, lower right, upper left, right, and then lower right. So I work my way around. Immune system, we're talking about anaphylactic reactions, and this is where we're going to get the information. What are you allergic to? Do you have any known allergies? Do you have any exposures? Patient says, I'm allergic to shellfish, and they're sitting at Joe's Crab Shack. There's a clue for you. Now the next question is, what's your typical reactions? Every time I've had a reaction, they've had to intubate me. That's not good. That means you've got to hurry and get them treated first. Any history of asthma? Asthma is an allergic reaction in the lung tissue. Do they have any tightness in the chest or throat? Are they having difficulty swallowing or speaking? Rashes, itchiness, upset belly. Do they have medications for their allergies? The one we're looking for is epinephrine. If they have an EpiPen, we can give that. We also in Colorado have the ability to give epinephrine that as EMTs we've drawn up. If you're IV certified, you can give that. But EpiPens everybody can give. So ask if they've got one. Look for the point of contact where they had the exposure. Maybe they got stung with the bee and look at it, see if it's starting to swell up. Look for rash or hives, swelling around the face. How's their speaking process? Are they getting good air into their lungs? All clues we're having problems with this allergic reaction, and we need to act as soon as possible. Musculoskeletal diseases that we get called for EMS are rare. Most of ours are trauma. And so we're going to talk about that as a part of the trauma assessment. It's all hands-on. It's touching them and feeling where the deformities are, anything that's wrong with them. So we're looking for history of prior injuries. I've torn my calf muscle. Now I've got pain in my calf muscle. Do you think they're related? Yes. Do I take blood thinners? That could be increased risk of bleeding into the tissue. Does some people have underlying medical conditions that make it more easy to fracture stuff? Or history of, maybe they're a combination. Maybe they had a medical problem that caused a traumatic injury, or they had traumatic injury that caused them to have a medical problem. So don't be afraid to ask questions and make some assumptions here, and always lean towards the making sure the patient is taken care of the best way. When we're looking for physical examination on these musculoskeletal, we're using the mechanism of injury to kind of focus in on where we need to be assessing, but we're looking for deformity, things that are not right when we look at them. Look side to side. If the left leg looks different than the right side, maybe there is a problem. We do hands-on. We touch it and then say, does this hurt? Do we feel anything that doesn't work right? Crepitation is bone grating against bone. Do not force crepitation, but if you feel it by accident, that's something to note. And if they have multiple injuries or a high mechanism of injury, or mechanism of injury, or they're unresponsive and cannot tell us where to focus our exam, we need to do a head to toe. And with their unresponsive or serious patient, we do head to toe, not like the kiddos we just talked about, where we might do toe to head. These are critical patients we're doing a head to toe, and we're going to talk about that in more detail as we get through here. So once we gather all this information, kind of get an idea of what might be wrong with our patient, we're going to do some critical thinking and make some decisions. You'll hear some people say EMTs don't diagnose, some people say we do. We're going to get an idea of what's wrong with our patient. You can call it whatever you want. You're going to use the history, the physical exam, and the vital signs to try to put a picture together of what might be wrong with your patient. If you ever watch this TV show House, what he does is differential diagnosis. They look at the symptoms and put up every possible cause of those symptoms. and then they look for ones that have the potential for being what's actually showing up in your patient. So you kind of rule out things as we go. I'm having chest pain. It could be a respiratory problem. It could be cardiac. But I'm having, I got a history of emphysema, and I'm having rales and rhonchi when I breathe, but I'm not having any changes to my EKG. So now I can lean more towards the respiratory cause. So that's what we're talking about, diagnosis. It's not the absolute. If you misdiagnose, it's okay. Always go a little bit more concerned with your diagnosis, and maybe a little bit more drastic than you really think it should be. The good thing about EMS is we work in pairs, and usually your partner has more experience than you, or you have other people on scene that can help you. Or sometimes you get lucky and the patient tells you what's wrong with them. That's always a good one. So there's no right or wrong way to do an assessment or a diagnosis or kind of compiling all your information. That's why we work together. If you ask 10 people how to assess the chest, you're going to find 15 different ways to do it. My recommendation is you watch how everybody else does it and take the good pieces that work for you and put them all together and come up with a system for you. But don't forget what the other person did that maybe you don't think you need to use right now, because someday that might come in handy. That little trick that nobody ever uses because it's an old school process and you just heard of it one time, it might come in handy someday. So start interviewing the patient. In the hospital, they've got plenty of time. They've got hours to interview and do assessments and do testing. You've got about 2 or 3 minutes at the most. So we're going to have to push this up a little bit faster and then make a quick decision on what might be wrong with your patient. So you assess the patient, get the differential diagnosis, exclude what's not there, and then fit a final diagnosis. We're going to push that process pretty fast through emergency medicine. So we want to rule out the life threats. What's going to kill him now if I don't treat it? That's the ones we want to focus on first. Start talking to the patient, the family, the friends, everybody around. You're doing the physical exam at the same time, or your partner is. If something says, hey, could be wrong and it could be serious, let's treat it and rule it out. And then just figure out where we go from there. But treat the critical things first, and then you'll be fine. The other problem that complicates things is you may have to deal with 20 patients at one time, or even 2 can get confusing. So if you go on a call, the dad is having chest pain and now the mom is having chest pain too, you've got 2 patients. So start thinking about that as a potential when you're dealing with things. So very important to kind of pay attention to what's going on around you, form that quick diagnosis, and treat what's life-threatening first. So she's getting a good information. I will say in this picture that the bed rails should be up. The patient should probably be on oxygen based on what I see on the screen on the monitor behind her. So, yeah, good picture. So be efficient. What you want to do is get your patient to the hospital and treat it as quick as possible for their benefit. Plus, you need to be available for the next call because other people are going to need you too. The other thing about being an EMS is it's a very uncontrolled environment. You're going to try to use what you can, the tools you have, the skill sets you have, to focus in on what might be wrong with the patient that could kill him now if we don't fix it. If it's something that's not going to hurt him now and you miss it, it's okay. We're going to do what we can to keep the patient alive. You're going to use the quick steps, just the ABCs, the head-to-toe rapid assessment, and try to put the pieces together. You may not know what's wrong with your patient by the time you get to the hospital, but you've treated all the life threats you found. That's perfectly fine. Now the doctor can take the time to figure it out. The good thing about all of our doctors here in town is if you wait to the right time to ask them after they've got the patient settled in and they've got a break, you just say, hey doc, this is where I was thinking with going with this patient. What do you think? And most of them here will actually start talking to you and say, well, why were you going that direction? What did you see? And they will guide you back to what the correct answer is, or tell you, hey, you had it just right. That's how I would have got it too. But they're really good to work with there. We're going to learn shortcuts. That's what doctors are doing all the time, ways to get from point A to point B a lot faster. We're looking for patterns. You can tell a chest pain patient that's having a heart attack pretty quick, and then you're going to do the diagnostic EKGs and send them to the hospital so you can prove it. But you're going to get some pretty good clues to kind of narrow it down. Just don't get too confident that you're sure of what's going on. Diabetes or a low blood sugar looks a lot like stroke, and it looks a lot like alcohol intoxication, looks a lot like drug overdose. All four different things treated different ways, but with a little bit of skill and a little bit of assessment, you'll know the difference between the two. So think about that when you're looking for the shortcuts, but don't be afraid to try things. Representativeness, what does it look like? What could it be? If a patient had a hysterectomy 2 years ago, it's probably not ectopic pregnancy. So we can rule things out. Don't be overconfident. Don't say, yeah, I've seen this 50 times. This guy's always drunk. We had our one town drunk named Otis in our town go on a call on him about once a week for alcohol intoxication. One day we get called to the jail. They got him in the back of a squad car, and they say he's just not getting out for him, which was unlike him. So we get there. I get in, check him. He's not breathing. He had a blood alcohol of 0, and because of the withdrawal, he had stopped breathing. But everybody was so confident that he was just a drunk that they didn't even check to see if he was breathing. We got him back. We gave him some alcohol at the hospital and got his blood alcohol back up, and he started breathing okay. But those are just things that we kind of pay attention to, the possibilities, and don't get overexhausted or overexcited about a diagnosis. The good thing about EMS is there are so many different possibilities. You aren't going to have the same call twice with the same patient. So love the ambiguity. Love the chance to go out there and try to figure out what's wrong. Know you have limitations. We do not have all the resources of a hospital. We've got enough resources just big enough to carry in the back of the ambulance, and you don't have multiple years of med school and residency to learn how to do this. So just be the best you can. Always think of treating the life threats, and then continually looking for ways to improve yourself. I know lots of EMTs that take the paramedic refreshers on a regular basis just to get that extra knowledge so they understand a little bit more. And then when they go to paramedic school, if that's their direction, they've got a good foundation to start with. But even a well-trained EMT with a little bit of extra knowledge is good. So start forming that little diagnostic in your head, put that chart up on the wall like Dr. House, and see if you could start crossing things off. And then never be afraid to learn from others. Ask questions. Look at how they're doing things. And then after the call, sit back with your partner and say, hey, what do you think was wrong? What do you think we could have done better? One good thing we do at the Colorado Springs Fire Department, I assume they still do it, sorry. They do case reviews where they will take a interesting medical case, and they will go from the 911 call. They'll have the dispatcher come in that took the 911 call. They'll play the call. They'll go with the first crew on scene, the EMS crew that transported. The ER doctor would talk, the surgeon, and sometimes the rehab people. If we're lucky, they get the patient in there even and have the patient give their side of things if it was a good outcome. So it's like 2 hours long of discussion about what happened in this one case, and we all learn from it. It's not really pointing fingers. It's not trying to say somebody did something wrong. It's saying, hey, what can we do to make this better next time? And as always, if you have any questions, write them down, bring them to class, and we're happy to talk about them. So thanks, and enjoy the rest of your night.